Okay, so now we're going to talk about anemias, and this one will be kind of lengthy as well because there are different kinds of anemias. The most common cause of anemia in pregnancy is iron deficiency. Iron deficiency anemia can lead to preterm birth, low birth weight. Normally, the fetal iron level is going to be normal. It depletes the mother's iron, but if it's severe, it can affect fetal iron stores. Iron deficiency anemia can lead to hemorrhage and to a lower tolerance for blood loss in labor or postpartum. Management, usually we supplement with 325 milligrams of iron daily. If they're not able to keep oral iron down, then iron dextran injections can be given. It can be given IV. There's a risk of anaphylaxis. It can be given IM. Those are very painful injections, and it tends to stain the subcutaneous tissue. So you have to use the Z-Track method. But typically, iron deficiency anemia, we're going to supplement it. Folic acid deficiency can also lead to anemia. It's a fairly common deficiency. This is more likely with a poor diet, people who boil their food with large volumes of water, alcohol abuse. If they have some sort of hemoglobinopathy, something that has different about the way their hemoglobin is structured, anticonvulsant medications, more than one fetus, a multifetal pregnancy, frequent pregnancies, and bariatric surgery. All of those could contribute to folic acid deficiency. What does this look like? Well, they look anemic, they're pale and weak and tired, but also they may have a swollen, irritated tongue, and their skin may be rough. Folic acid can be supplemented orally as well. Folic acid deficiency rarely occurs in the fetus. Sickle cell disease is an autosomal recessive disorder, and it's classified as anemia, but it really has a lot of other things going on. What happens is, under certain circumstances in a person with sickle cell, under certain circumstances, their red blood cells change from round ones that like to go through the vessels easily to sickle-shaped ones that tend to pile up. Those piles cause ischemia. That ischemia is very, very painful. So sickle cell is characterized by painful crises. It's very common for people with sickle cell disease to be accused of drug seeking or lying about their pain. And so we ignore that pain. But remember, when we're ignoring that pain, we're ignoring ischemia. It is tissue damage. It's like a heart attack, but in your bones or your muscles, whatever tissue is not getting perfused. Those sickled cells also break down more quickly, which causes anemia. Someone with sickle cell trait will have some sickling, but they have a normal red blood cell lifespan, and so they tend to have a lot less complications. In pregnancy, sickle cell crisis can cause miscarriage, intrauterine growth restriction, stillbirth, preeclampsia, infection. Pregnancy can also cause the person with sickle cell to have more frequent pain crises. Okay, management, we want to monitor this patient closely for complications. They're probably going to get serial ultrasounds for growth to make sure the fetus is growing. They're going to get repeated NST and BPPs in the last trimester. Any infections are treated very aggressively because infection is one of the triggers for sickling episode. Crises need to be managed. It is really, really important that sickle cell crisis is managed with opiate pain medications, not Tylenol, not Toradol, opiate pain medications. Morphine is the preferred one in the textbook because it vasodilates better. In reality, a lot of patients with sickle cell complain of itching with morphine. Sometimes Demerol is used, sometimes Dilaudid is used. But opiate pain meds not only relieve the pain, but they help, or they relieve some of the pain. They help vasodilate somewhat, and that allows for those pileups to break loose. We also want to oxygenate them if they're not maintaining O2 sats, and hydrate. Hydration expands the blood volume and again allows for those piled up sickled cells to be able to separate and break through. Some experts recommend prophylactic transfusions for patients with sickle cell just to prevent crises, but that's controversial because transfusion also has some risk. This patient should labor side lying instead of on their backs. They may require oxygen in labor. Hypoxia triggers sickling. They need to be really well hydrated because dehydration triggers sickling. Epidural or spinal anesthesia is recommended. The vasodilation can be a benefit there. Vaginal birth is preferred. Thalassemia. Thalassemia is another hereditary disorder. And it's when the red blood cells have not enough hemoglobin. So insufficient hemoglobin is produced. Beta thalassemia minor, those patients usually don't have symptoms. Beta thalassemia major, what happens is those cells break down really frequently. And so the bone marrow keeps trying to make more and more and more. So the bone marrow is overactive and it tends to expand, trying to make more red blood cells, which causes a lot of pain in the bones, but it also causes the bones to become deformed. Patients with beta thalassemia major usually have a shortened lifespan, and pregnancy is unlikely. But if they get pregnant, they can become severely anemic. They can go into congestive heart failure. And the management is going to be similar to sickle cell, but they're going to need those transfusions. They have to have blood transfusions regularly. In the next section, we're going to talk about some pulmonary disorders in pregnancy.